that all of us, oh, okay, got it. And I think that this is a topic that we're all in a learning process about. So I want to acknowledge that I think we both do our best in terms of language, but I might make mistakes, Megan might make mistakes, and that's part of the learning process. So please feel free to point things out to me so I can improve in the future as well. So in talking about gender affirming care, specifically in adults, what we're going to cover today, I wanted to start with some basic terminology so that we can all be on the same page. I know that there's been a lot of media coverage of this topic, a lot of debate around this topic, and so I want to be clear about what we're talking about here. So I thought a good way to start that would be to sort of unpack this acronym LGBTQIA+, and recognize that this acronym overall is talking about sex, gender identity, and sexual orientation. And so to sort of break those things down, the lesbian, gay, bisexual refers specifically to sexual orientation or romantic attraction, whereas transgender refers to gender or gender identity and really encompasses a wide range of people that identify as gender nonconforming, gender diverse, and I'm going to talk a little bit more about that later. But this is an umbrella term for people that don't fit into a binary gender. Queer and questioning. Does someone have a comment? All right. Can refer to people's gender identity, but also sexual orientation. The A refers to asexual or agender, and so that it can be refers to gender identity or sexual orientation. And then the I refers to intersex, which is a sex, so refers to biological aspects, and those individuals can have variable identities in terms of gender. So wanted to just kind of talk about sex to start with. I think that there's a lot of debate around this topic. I looked up several definitions, including Oxford and Merriam's, and then some sort of more medical and scientific definitions that all essentially say, you know, sex is sort of this male or female categorization based on reproductive organs and structures and their functions. I think that if we really break that down, we can see that there is more than just a male and female gender, and this should also include intersex. Has also been retermed disorders of sex development, and this is referring to people who have differences in genitalia, hormones, anatomy, or chromosomes that don't fit neatly into this binary category of male or female sex. And so to illustrate that a little bit further, I think we can all remember from medical school that there is actually a wide variety of different types of combination of sex hormones that can contribute to variations in phenotype, variations in genital phenotype, secondary sex characteristics, but also fertility. Other contributions to sex is gonadal, so the presence of functional ovaries or testicles, or non-functional ovaries or testicles. And so again, various variable types of fertility. And then of course, like among this, we have a very wide variety of anatomical and phenotypical differences amongst individuals, both with regard to genitals and secondary sex characteristics. And then of course, kind of at the base of this is hormones, which can be affected by genetics and environment. So if we look back to those definitions of, you know, a male or female sex that depends on your anatomy and reproductive capacity, you can already see that there's a huge variety of those things that exist naturally amongst our species. Just to illustrate this a little bit further, this is the Prater scale, was developed by a Swiss endocrinologist in the 50s that shows differences in virilization. This was specifically developed around congenital adrenal hyperplasia in intersex individuals. And so we can see that there really is a wide variety of anatomical and phenotypical differences having specifically to do with genitals, but that can apply to many other parts of the body as well. And then I'm not going to go into this slide in a whole bunch of detail, but I did just want to point out, so these are some of the genetic and hormonal causes of differences in sex development. So these are just some of the most common types of genetic and hormone differences that we see in individuals that can lead to variations in infertility, in phenotype, in anatomy, in gonads. And so really quite a huge amount of natural variability in our society and in our human species. And so given all of that sex itself is so widely variable, I don't think it is too surprising that gender can also be that. And so I wanted to talk about just some basic definitions of gender. So gender is the social construct of norms and behaviors that exist in a society over time. And so gender can differ between societies over time, but really refers to behaviors and roles within that society. And so kind of right now in our society, we have sort of male and female gender, but increasingly we're having other types of gender, non-binary genders, for example. Gender identity refers to one's own deeply held sense of their gender, whether this is a man, woman, neither, both, or something completely different. And again, I'll go into a little bit more detail. A gender identity is not something that is immediately visible to someone, right? It is not something that we necessarily know unless we talk with someone about their gender identity. Gender expression, though, refers to how we outwardly present ourselves in our society. So this can be through behaviors, clothing, voice, or other perceived characteristics. And again, I think traditionally or more in the past, gender expression has been either sort of more masculine or more feminine, and I think we can all recognize that we probably fall on some spectrum of that scale. You might be familiar with the gender unicorn. I just wanted to throw this in here because I think it's a good illustration that's very popular right now that talks about these different concepts. And so given that we've sort of talked about the fact that there are maybe more than two different genders, how many genders are there? I want to acknowledge that within a binary system, we have cis male or men and cis women or females. And so cis, harkening back to organic chemistry, being one's sex assigned at birth aligns with one's gender identity. But we also have sort of in the past terms like male to female or female to male. So a person who had a sex assigned at birth at male, but identifies now as female, and vice versa. And all of these gender identities exist within this sort of binary, which we think of as two poles of the spectrum traditionally. So female on one side or feminine, and then male or masculine on another side. And I like this illustration because I think it kind of highlights like, what is feminine in our society, right? Is Barbie like the absolute pinnacle of femininity, and G.I. Joe is the pinnacle of masculinity? And so like, where would each of us as individuals really fall on this spectrum? I bet that a lot of us probably don't feel like we fall exactly on one pole or the other of this spectrum. And so there are many different types of transgender or gender nonconforming or gender diverse identities. I put this list here just to kind of illustrate that there's some of these you've probably heard of, and many that you maybe have never heard of. But gender fluid, so a person who may identify more masculine in one day, more feminine another day. Gender variant, so something different from our norm. There's non-binary, so just not on this spectrum that we have here. Two-spirited, queer, again, being sort of like a very general term that can include a lot of different types of definitions of identity. And you can see some of these other identities in here that are from different cultures or things that people have chosen for themselves. I just included this because these are some pictures that I just saw on the internet that are different kinds of ways of looking at gender, right? We have this like two poles of one spectrum, but imagine if we looked at gender in kind of a different way, right? Not two poles of a spectrum, but some other way that is, we can, exist within a gender spectrum in a different way. And then just a quick note on sexual orientation. So sexual orientation has to do with who we're romantically attracted to. It is separate from gender and gender identity, and those are not related. And then lesbian, gay, and bisexual really do exist kind of, again, on that binary gender system. But there are lots of other types of sexual identities and sexual orientations. Again, I listed a few here. I'm not going to go into a great detail about that, but I just want to acknowledge that as gender becomes more fluid, as a gender diversity becomes more of a part of society, people are finding new ways to identify their sexual orientation that's consistent with that if they're attracted to more than one gender. So now that we kind of have like a common definition of some of these basic terms, let's talk about gender affirming care and what that is. So I have a definition here. I actually came up with this based on a lot of different reading and podcasts that I listened to. So gender affirming care is care that respects a person's gender identity, understands the impact of gender and identity on health, and supports a patient in aligning their physical body with deeply held beliefs about their gender identity. And I'd like to point out that gender affirming care then is for everyone, right? We provide gender affirming care to any of our patients that come into the clinic. If we had a cisgender woman that came in with some hirsutism, in addition to wanting to work that up and figure out what was going on, we would also want to help that patient if she felt like that was really in conflict with the feminine aspects of her identity. We would treat the same, a male patient that came in distressed about gynecomastia with the same amount of concern. An intersex woman who comes in, who was born with ambiguous genitals, maybe has some poor breast development and doesn't know their karyotype. We would make efforts to help that person figure out what are the most important biological pieces of information that we need to know in order to give that person proper screening, and how we can help them to align their identity and their physical body with their identity in order that they can have a happy family life. And sexual life. And so I think that type of attitude towards care is no different than with a person who has gender incongruence, gender dysphoria, who identifies as transgender or somewhere in the spectrum. Additionally, I wanted to point out, we talk about gender affirming care, and really a lot of this care, when we're talking about medical treatment, we're going to be doing this under the diagnosis of gender dysphoria. And this specifically refers to the discomfort or distress that is caused by a discrepancy between a person's sex assigned at birth and their gender identity. And I really want to point out that gender dysphoria is not something that every transgender or gender nonconforming person will experience in their lifetime. They may not experience it consistently through their lifetime, but that this diagnosis of gender dysphoria helps to facilitate healthcare access. And I'm going to talk more about that diagnosis in a couple of slides here. This is a study that I looked at that kind of talks about how gender dysphoria or gender incongruence can be extreme or mild, can be varying in its associated distress with the patient, can be fluctuating or permanent, more or less associated with dysphoria with one's anatomical features, and can be accompanied by a wish for partial or complete transition. I think this really gets back to the variety of different identities that people can have. And different gender identities that people can have, and they may not want this from one pole to another transition, right? Going from male to female. So this was a study done on treatment requests in a clinic, a gender identity clinic in Amsterdam. So these are people who are going in for treatment. And about 2/3 of these patients wished for a complete social and medical transition. About 1/3 wanted a complete social but only partial medical transition. And about 3% only wanted a partial social and medical transition. So again, getting back to, there's a very wide variety of types of gender affirming care and desires and needs that our patients may have that are not just, I was assigned one sex at birth, I identify as the opposite thing, and I need help making a complete transition. So being really cognizant of that when we care for these patients. Why is it important to talk about gender affirming care? I think, first of all, the Endocrine Society has, and our research has indicated that there is a durable biological underpinning to gender identity that is important, and that medical intervention for youth and adults is effective, relatively safe, and has been established as the standard of care. And so as we would provide that standard of care for any of our patients, for any of their health concerns, this is something that we want to be able to provide for these patients as well. And from a more patient-centered perspective, gender affirming care is patient-centered primary care, and that's what we practice as primary care physicians and as family physicians. It is also life-saving care. And then we will review a little bit of legislation and how this is going to be affecting our patients' access to care. I did want to cover a little bit of epidemiology so that we understand a little bit more about this population. Understanding that the lack of adequate language to study this population, as well as the marginalization of this population, has made people very difficult to study. So again, our language has changed a lot in the last 20 years in terms like transvestite, transsexual, to gender and non-congruence. And so studying this population, it's important that we have accurate language in order to be able to do that moving into the future. But our data is kind of difficult. So in even trying to come up with the population of transgender people in the United States, it's difficult to find an absolute conclusion, but somewhere in between 0.1% and 2% of adults, depending on if you're doing studies in a clinical setting or if you're just doing general population studies. And for intersexed individuals, this is somewhere in between 1 in 1,000 and 1 in 4,500 births. And this is really specifically people that had a significant enough disorder of sex development to warrant some kind of evaluation. And this is important as intersex people do have high rates of gender dysphoria, so also people that are going to need gender affirming care. This is just a map that shows population density. So higher population density in the states with a dark blue color, lower population density of transgender people in the light color, and then black color is no data. Important to talk about morbidity and mortality in this population. Especially as it is a marginalized population. So much higher burden of disability, with 71% of gender minority Medicare beneficiaries being entitled to disability, higher rates of multiple chronic conditions, and higher rates of asthma, diabetes, COPD, and HIV. It's also been found that this population has higher rates of cancer diagnosed at late stages and is less likely to receive treatment, and does have a worse survival rate for certain types of cancers I've listed here. This population is also more likely to be affected by substance use, with one study showing that 26% of transgender people use substances to cope with discrimination, and higher rates of smoking as well. This study talks about cardiovascular risk factors in transgender population versus overall population, and then specifically in transgender males versus cisgender males. And you can see that there's a higher rate of cardiovascular risk factors in a transgender population. This is in a study that was people who were coming, wanting gender affirming care, so had not yet received hormones. And then important also to talk about mental health. There's a higher rate of depression and anxiety in this population, 4 times higher for depression and 2 times higher for anxiety in one study. An increased lifetime risk of suicide, with rates as high as 40% of a lifetime prevalence of suicide attempts, compared with about 2 to 9% in the general US population. And then increased rate of or prevalent or use of mental health services for all things, but then also specifically for self-harm. Also talking about social determinants of health is important in primary care. Important to acknowledge that many transgender and gender nonconforming people have lower educational attainment, income, are less likely to have health insurance, more likely to live in low-income neighborhoods. And then specifically with transgender women, this is a population that's been heavily affected by poverty, homelessness, and incarceration. So understanding that this is a population that could be largely missing from our data due to those factors. So to kind of talk about why gender affirming care is life-saving care, there's been shown to be a reduced risk of suicide, suicidal thoughts and attempts with the introduction of gender-affirming hormone treatment versus individuals who are not receiving hormone treatment, but wanted hormone treatment. Also reduced prevalence of anxiety and depression, and improved quality of life scores for people who are receiving specifically gender-affirming hormone therapy versus those who are not able to access that therapy. And then increased access to preventative care. I read a really interesting study about high rates of not having ever had cervical cancer screening or regular cervical cancer screening in transgender men due to triggering of gender dysphoria, and then also kind of like a poor provider-patient relationship. But it was noted that good provider relationships with trust and acceptance of the transgender identity was associated with an increased uptake of cervical cancer screening. And overall, this is a population that has lower rates of cervical, breast, and colorectal cancer screening. So it's important from our primary care wheelhouse. I just wanted to touch on interventions, medical interventions with intersexed individuals or people with disorders of sexual development, and acknowledge that surgeries and genital surgeries continue to happen worldwide for these children at a very young age, mostly at birth. and that these surgeries are associated with a variety of different complications, often decreased sexual function, and high rates of dissatisfaction later in life with the surgeries, appearance, and sexual function, and that there is a high rate of gender dysphoria and subsequent gender transition after puberty for this population versus the general population. Many organizations have called for a stop to early genital normalization surgeries, but again, this is a population where not great data is collected. It's not something that all hospitals are tracking these types of surgeries. And I point out this phallometer on the right being, I think, not something that is as commonly used, but essentially that the length of the phallus at birth was sort of used to determine gender. And I think that the way that these surgeries are happening has become a more advanced and a nuanced process, but understanding that obviously that is way too simplistic to decide on someone's gender for the rest of their life. So gender affirming care is primary care. In so many different ways. It is advocating for our patients, it's ensuring equitable access to care, supporting bodily autonomy. We want to provide our patients with accurate education and information that is applicable to their body, their sexuality, their life, their body parts. And then, gender affirming care is also providing primary care, preventative screenings, reproductive health care, mental health care, and then, socioeconomic resources. So we're going to kind of cover different aspects of gender affirming care. I'm going to talk a little bit about legal and social transitions, and then I'll hand off to Dr. Haughton to talk about medical and surgical aspects of gender affirming care. I'm not going to go into a whole lot of detail about types of gender affirming care in terms of processes that we would be involved in terms of legal support, but depending on the state, there are different kinds of requirements for getting a name change on a birth certificate or ID, passport, or a sex marker change. So that would be the M, F. In some states, they have the option of an X, but those are often processes that we would need to be supportive in, giving some kind of documentation in order for that to occur. And then social transitions, right? This is supporting our patients in the social aspects of their gender expression and gender identity. This, I think, starts with preferred names and pronouns, but also supporting our patients in being able to express themselves in the way that is best and healthiest and safest for them. So where does gender affirming care start? I think first we have to think about language, and I'm going to talk a little bit more about terminology and language. But gender affirming care can start even before a patient reaches our clinic or our office, right? We might send out forms or registration forms that they would get through, an app, something like MyChart. So it's important to think about when we're thinking about providing gender affirming care, do the forms that we send out and the interactions that a patient is going to get before they even come to the office, are they able to specify a preferred name, a preferred pronoun, specify their gender identity on those forms, and do we have those things accessible to them? This starts with the way that we greet patients, so who they see at reception, how they're called into the clinic. Do we step out and say Mr. or Mrs.? Can we transition to some other way of calling on patients, for instance, just using a last name or first and last name? This is important in staff training. We need to think about our receptionists and other support staff. Do they have adequate training to feel comfortable with providing care and interacting with gender nonconforming patients? And I think it's important to recognize that not everybody feels comfortable with those things. And so that can make things difficult for our support staff. And we need to give them adequate training so that they know what to do. And then, of course, pronouns is an important thing in how we address our patients, asking our patients what pronouns they prefer. I've also read a number of different articles recently that doing this universally might not be the best thing. If you're in a conservative northern part of Idaho, is that going to alienate some of your patients? But finding ways to make our patients feel welcome. I think that using the pronoun pin on your own lapel is a good way of opening that conversation for patients, and then making sure that the physical space that we're providing patient care in includes gender nonconforming and transgender patients, right? Do we have posters, educational information, handouts that represent those people and are applicable to those patients? Pronouns, lots and lots of debate about pronouns. Most common ones being she, he, and they, and here, so there's different aspects of pronouns. I'd like to point out just with this slide that there are lots of different gender neutral pronouns that exist, being many of these here. So these are pronouns that people could potentially use if they were gender nonconforming or didn't identify with the he or she pronoun. Most people tend to use they and them, which I think, makes it a lot easier for those people who are unfamiliar with these other pronouns. So just being familiar with it, there are a lot of these different pronouns. EPIC, at least in our system, has several of these available. And then talking briefly about anatomy, just thinking about the way that we refer to anatomy and other aspects of healthcare when we're talking with transgender patients. For instance, instead of saying things like clitoris or vulva, you can talk about erectile tissues, external genitals versus internal genitals, internal gonads, external gonads. Instead of talking about breastfeeding, you can refer to chest feeding. I'm not going to go over all of these different terms. There's many different resources available, both at the bibliography of this presentation and on the internet, where you can get information about the best way to think about the types of vocabulary used frequently and how you might make that more gender neutral and comfortable for those patients. And just in terms of documentation, it looks like some of my little symbols, these are supposed to be little arrows here, and didn't come through. But when we talk about gender with patients, right, we also want to make sure that in our documentation, we're talking about people's identity and their gender in a way that feels that is good for our patients, especially now that patients can see a lot of this documentation. So instead of talking about transsexual, transvestite, or transgendered, we can talk about things like transgender man, transgender woman or person. We can talk about someone's affirmed gender. In terms of talking about sex, the word hermaphrodite we should not use, instead use intersex. We can talk about, instead of biological male or female, we can talk about natal sex. Again, instead of saying born male or female, we can talk about sex assigned at birth. And then sort of previously, female to male or male to female was a common term. We're tending towards these other abbreviations, which are essentially male assigned at birth or female assigned at birth, or some variation of this. And then talking about transitions, right? This is that process of someone going from sort of one gender expression to another gender expression or identity. Instead of talking about sex changes, we can talk about medical or surgical transitions. And then instead of talking about sex change operations or reassignment surgeries, we can talk about gender affirming surgeries. That being said, not everything that we can do in our notes can be as congruent with our patients' desires in terms of how they talk about their identity or their experiences. Really, most of our medical treatments, we only have one option, and that is to put this under the ICD-10 diagnosis of gender dysphoria or gender identity disorder. The American Academy of Family Physicians has advocated against for removing policies that require stigmatizing diagnoses like this in order to cover gender affirming care, but we are not there yet. And then worldwide, there is the ICD-11 code that has replaced things like gender dysphoria and identity disorder and transsexualism with gender incongruence of adulthood or childhood. And this gender diagnosis has been moved out of the mental and behavioral disorders section into the conditions related to sexual health. This is really recognizing our understanding of gender at this time, and that this is not a mental health, this is not a mental illness, and should not be classified as such. That creates stigma, and that we should move towards ICD-10. I've heard that that might be happening in the next 3 years. I've also heard that we're like 25 years behind, so we'll see. And then to talk more about sort of social aspects of gender affirming care, how we can support our patients in their gender expression. So a lot of different things that people use to in their gender expression. They're not hormones or surgeries. So voice training to help learn how to have a more higher pitched or feminine voice, or lower pitched, more masculine voice. There is wigs or hairstyles, makeup, hair removal. And then I'm going to talk more specifically about tucking, binding, and packing. So there's a lot of things that people are going to come to us already doing to help their express their gender in a way that feels good to them. So acknowledging what those things are, we can talk with our patients about those things, but then there's also things that we should be aware of in terms of some of these different gender expression or passing things that people do. So I want to talk about tucking really briefly. The goal of tucking is to minimize the appearance of a genital bulge. Different methods include taping, layering of underwear, there's control briefs, and gaffs or V-strings. I have some of those featured above. And tucking is a process of sort of pressing the testicles into the inguinal canal, and then wrapping the penis posteriorly and using some sort of tape or some sort of binding to keep that in place. Risks with this include skin irritation just from close skin contact, and sweat, UTIs, and dehydration, people not wanting to drink or urinate because they have to kind of unwrap sort of a complex a tucking setup. There's the risk of reduced fertility because of the exposure of the testicles to the increased temperature, and then increased risk of testicular pain and torsion. So things we can do to educate our patients, we can talk with them about being really careful to clean and thoroughly dry the area before doing this. It's important to do hair removal so that you can minimize the risk of irritation from stubble or hair, ingrown hairs. Take days off from tucking, never use duct tape for tucking, and then switching methods of tucking to ones that are less restrictive. Binding is something that we will find is common in transmasculine patients, so minimizing the appearance of breasts or of a large chest. Different methods include taping, layering of sports bras, ace bandages, and then there are on the bottom here, you can see very specific binders made for this purpose. Risks, again, include skin irritation, pain, postural changes, nerve impingement, muscle atrophy, and lung compression from not being able to take a deep breath. And things we can educate our patients about: making sure to clean and thoroughly dry the area, making sure to wear a binder that is the right size for us, and to use the correct binding methods. So having the breasts pressed towards the chest instead of downward. Using breathable materials. Don't use duct tape, saran wrap, or ace bandages to bind. They can be really tight and can kind of get tighter throughout the day, causing difficulties with breathing. Take days off from binding, no more than 8 hours, and then making sure to take deep breaths and use stretching, and then careful with exercise. And then there's also different kinds of packing, padding, and prosthetics that can be used. So packing specifically refers to creating the appearance of a genital bulge. This can be anything from a rolled up sock to much more expensive silicone models that can be, there's either specially made underwear that can fit a silicone model, or you can just put that in some underwear. Padding refers to the use of shapewear or silicone breast, hip or buttock enhancers. You can also have padded bras with pockets or mastectomy bras that can be used for this. And then there are a number of stand-up to pee devices that allow for someone to urinate in a standing position without a penis. These can range from a disposable paper or plastic device to a silicone mold that looks like a penis. From here, I'm going to let Dr. Haughton take over.
All right, everybody. Can you guys hear me okay? Cool. Sweet. Thanks, Sarah. All right. So yeah, so now we're going to be moving on more to some of the medical things that have to do with gender affirming care. So if you don't mind moving the screen, Miss Sarah or Dr. Bardwell. So in general, for cancer screenings, we kind of look at is if the patient has a particular body part or organ or otherwise meets criteria for screening based on risk factors or symptoms. Screening should continue regardless of hormone use. So that means that if you are somebody that still has a cervix or someone that still has a uterus, you still need to go through pap smears, everything like that. Transgender people should begin bone density screening at age 65, no matter how you identify. That is definitely recommended. Ages 50 to 64 should consider a DEXA screen if they have risk factors for osteoporosis, such as like Caucasian Asian race, older age, multiple drinks of alcohol per week, more than 10, corticosteroid use, that type of thing. If transgender person has undergone gonadectomy and has a history of at least 5 years without hormone replacement, they should also consider a DEXA scan. And then studies suggest that cardiovascular risk is unchanged among transgender men using testosterone compared with non-transgender women. So just some things to remember. Just because someone is undergoing transgender care does not mean, or gender affirming care does not mean that they don't need the regular things that we get to do on a daily basis. if you can change the screen. So yeah, with breast cancer screening, again, we recommend getting this every 2 years, but once at the age of 50, and then starting at age 50, or if they've had 5 to 10 years of feminizing hormone, we also suggest that in transgender women. And then if say they just started doing feminizing hormone at age 50, we like recommend you waiting at least 5 years before you have your first screening mammogram. And then overall, transgender women have reduced risk of breast cancer compared to cisgender women due to less overall or cyclical exposure to estrogen. And but one study that we were looking at did show a 46-fold increased risk of breast cancer in transgender women compared with reference men. And usually those occurred at a younger age and occurred after a relatively short hormone treatment duration. Next, please. So prostate is often conserved in trans women even after vaginoplasty. These patients can still be at risk for prostate cancer. And often transgender women often, again, have a delay in diagnosis just due to access to care. And so sometimes those forms of prostate cancer are actually more aggressive. More likely to find prostate cancer in trans women who started hormones after age 50. And the anti-androgens that we put patients on may decrease your PSA result. So sometimes you need to adjust the upper limit of normal when you're testing their PSA levels. Removal of gonads in addition to estrogen exposure may help to reduce risk for prostate cancer and BPH. And decision to perform screening for prostate cancer in transgender women should be based on the guidelines for non-transgender men. Please move on. In ovarian endometrial cancer screening, generally, routine screening for endometrial cancer in transgender men using testosterone is not recommended. However, if there's unexplained vaginal bleeding, with the patient had testosterone-induced amenorrhea, you should check that out. That's important. Getting a hysterectomy for primary prevention of endometrial cancer is not necessarily recommended. And overall, there is increased ovarian cancer risk in cisgender women with history of testosterone treatment. Next slide, please, Sarah. And again, like we were kind of saying, cervical cancer screening, transgender men are still at risk for cervical cancer if they still have a cervix. Pelvic exams to obtain pap smears can be challenging in transgender patients. Again, that's why it's really important to have patient-centered care. You can, talk through the procedure with your patient. You can also offer to like bring a mirror or something so they can see what's happening while you're doing that exam. And then next slide, Sarah, please. Okay, and so then now I'm going to talk more about the actual medications. Again, so the criteria for hormone treatment, there's different guidelines. There's the endocrine treatment of transsexual persons. And then, and you can go over readiness criteria. And then, let's see.
Sorry, I added this slide. I wanted to point out that there used to be sort of a readiness criteria for starting hormone treatment, which meant that someone had to live for 1 year as the other gender or their preferred gender. That is no longer the case. And so I just wanted to make sure that people are aware of that.
Thank you, Dr. Bardwell. So kind of along with that, in the past, it actually was required for these patients to have a psychological assessment. They needed a referral letter from a mental health professional in order to start gender affirming care or hormone replacement therapy. And generally the kind of algorithm was like, get the letter from the mental health professional, then start hormones, and then you could go to surgery. Current standard of care is to let each transgender person choose the interventions they desire to affirm their own gender identity. So you'll see some patients that only do hormones, some people that only do surgery, or some are non-binary and might do different things. What's most important though is using the informed consent path, meaning you talk about the risks and treatment benefits, plan of treatment, and just know that they're always can change their mind if they're in the middle of the treatment. That's totally fine. It's, making sure the patient's in the middle of their care and kind of helping lead that. Next slide, please. Okay, so certain risks that you should think about is, as we have all talked, or we know, embolism. Data suggests that the route of hormone administration, patient demographics, and patient comorbidities all affect estrogen's link with VTE. Transdermal estrogen may be lower risk for VTE than other forms of estrogen. Thus, like if you have a patient who's smoking or has other risk factors, that might be a consideration to take in when you're deciding to start care. And then recommended to avoid ethinyl estradiol in trans feminine individuals. Let's see. Yeah. And then cardiovascular risk. Yeah, there you go. Perfect. Thank you. Cardiovascular risk is unchanged among transgender women using testosterone compared to non-transgender women. Again, shared decision making, you can calculate the risk depending on what age the hormones are started, the total length of exposure, and depending on, you know, working with your patient, you may be able to plug in your patients to our various risk calculators. You can choose which, if you want to use the risk factor for the natal sex or the assigned gender, or an average of the two. Again, that's working with your patients and creating that open communication. Next slide, please. So for feminizing hormone therapy, the goals are to the development of female secondary sex characteristic like breast development, reduction of body hair, reduction of muscle mass, or suppression or minimize male secondary sex characteristics. So like reversal of scalp hair loss, redistribution of facial and body subcutaneous fat, that type of thing. Sexual gonadal effects are reduction in erectile function, reduced sperm count, and changes in libido. This hormone treatment might change patients' emotional or social functioning, and it's usually done with estrogen, with an androgen blocker, and sometimes progesterone. Progestogen, sorry. Please change. Okay, yeah. So estrogen is the main class that we use, is estrogen 17 beta estradiol. It can be given via patch, and like I said earlier, sometimes that's better for people with higher risk for pulmonary embolism. They can be an oral, sublingual tablet, or injection. You can also give a gel or spray. Side effects can include migraines, mood swings, hot flashes, waking. Next slide, please. And then here's just like a chart of like how you start and how you can continue. So often you start with 1 milligram per day of the estradiol, and when they come back to you 3 months later, you can go up to 2 depending on what's going on. Next slide, please. And then the anti-androgens, so spironolactone is the most common one we see used. It helps to suppress testosterone production and helps to minimize male secondary sexual characteristics. Again, as we all know, this is a potassium-sparing diuretic, so higher doses is direct anti-androgen receptor activity. The most serious adverse effect is hyperkalemia. Patients might have polyuria, polydipsia, or orthostasis. So we also sometimes use 5-alpha reductase inhibitors like finasteride or dutasteride. Next slide, please. Again, here's another list. Yep, perfect. And then progestogen, sometimes we use that. The most commonly synthetic one is oral medroxyprogesterone acetate. Not as well studied, but sometimes there's evidence of impressed breast or areolar development. So sometimes people like that. Next slide, please. Again, here we go. Another chart with some information. And then here's a chart of things you need to make sure. If you have a patient going through transitioning, you need to make sure that you check their electrolytes every at initiation, 3 months, 6 months, and then 12 months, then yearly, because they're on that spironolactone. Make sure their potassium is okay. Checking on the lipids, and then again, checking the estradiol and the testosterone is important to make sure they're within the goal. Next line, please. Yep. Then for masculinizing hormone therapy, the 2 main goals are development of male secondary sex characteristics and minimization of female. So the opposite of the feminizing. Patients can develop facial hair, changes in voice, distribution of facial and body fat, increased muscle mass, increased body hair, and change in sweat and odor. Sometimes side effects may include vaginal dryness, clitoral growth, and cessation of menses. And that we usually do this with testosterone. All right, next slide. So the testosterone preparations we have for these patients are bioidentically equivalent to testosterone secreted from human testicles. Usually it's given via injections or topical. Usually transdermal testosterone gel is given in the morning, applying to the upper arms or shoulders, trying to keep that site dry for about 2 hours. Usually need higher dosing in transgender men more than in non-transgender men if you're trying to give them testosterone. Next slide, please. And again, here's another chart of different ways to administer the testosterone. Next slide, please. So yeah, like we've said before, you know, like working with your patient, the goal would be to titrate dose upwards through shared decision making. Usually you can see patients will have amenorrhea by 6 months. And once in the normal male physiological range, there's no evidence that higher doses of testosterone can result in better effects. And so it's important to also get a hold of your lab wherever you are to figure out what these levels are, what your reference ranges are. Again, measure your testosterone levels at 3 and 6 months. And it's also really important to look out for metabolic shifts, such as the onset of any thyroid disease, weight changes, diabetes, hormone imbalances, hot flashes, and migraines, and pelvic cramping. Next slide, please. And then again, like I was kind of saying, like ranges for serum, estradiol, total estrogens, all of that may differ on labs and techniques, and it can be really hard to interpret because usually when measuring for transgender patients, because usually the reference ranges are based on the intended hormonal sex, not necessarily for the gender of the patient. You can consult with your lab at your facility to figure out what those ranges can be. Next slide. And it's recommended that the testosterone, if the specimen is drawn at peak trough or in mid-cycle of the dosing interval, sometimes it can be difficult because there are rapid fluctuations in levels. Free testosterone can be measured, but total testosterone is reliable and readily available. So the best would be to monitor the total testosterone level. Next slide. And again, shared decision making. Some patients may desire a mix of masculine and feminine sex characteristics. They may choose testosterone, develop irreversible changes in their body, and then stop taking testosterone. Some patients might want to keep their breasts and their female body habitus, but would like a beard or would like to deepen their voice. So continuing to keep open communication with your patients to go over goals together, setting expectations, and being on the journey together is important. Next slide. So fertility options. So prior to transition, it's highly recommended to counsel these patients on the effects of the transition on their fertility. And then there are options to preserve fertility, like freezing. If a patient has retained their gonads, they might have the option to discontinue their exogenous hormones to increase their fertility. It can take 3 to 6 months to return their fertility. And it's also important to let your patients know that all transgender people who have gonads and engage in sexual activity that could result in pregnancy should be consulted on contraception. Fertility preservation options may include cryopreservation of sperm, oocytes. You can also use clomiphene citrate or HCG injections to stimulate spermatogenesis in the transgender women. And although testosterone therapy leads to an ovulatory state and amenorrhea, it can be reversible once testosterone therapy is discontinued. Next slide, please. And then surgical, last but not least. And so masculinizing chest surgery, usually the goals would be to sculpt a natural appearing masculine chest that matches the body's habitus. The most common technique is subcutaneous mastectomy via periareolar incision and inframammary mastectomy with free nipple grafting. Common complaints afterwards is post-operative scarring, nipple appearance, and contour deformities. Risk factors include high BMI, hypertension, prior breast incisions, and the amount of breast tissue resected. It's highly recommended that these patients stop smoking 4 weeks prior to surgery. And even though you have this surgery, does not totally eliminate the risk of breast cancer development for these patients. Next slide, please. And then the feminizing augmentation mammoplasty. This involves implant-based augmentation mammoplasty with prosthetic implant of silicone shoal or saline silicone. Recommended to allow at least 6 months of hormone replacement therapy prior to surgery to let hormone-related breast development to progress. It's usually a same-day procedure, taking about 2 hours. Next slide, please. And then just like overall, there's orchiectomy, which is removal of the testes. There's the vaginoplasty and vulvoplasty, which is the creation of vagina and vulva for feminizing surgery. Next slide, please, or next slide, please. And then for masculine surgeries, there is hysterectomy with bilateral salpingo-oophorectomy. Clitoral release, which I learned about, is ligaments around the clitoris are cut, releasing clitoris from pubis and creating a penis 4 to 6 centimeters long. And there's metoidioplasty, which is similar, and then a phalloplasty as well. Next slide, please. And then there's facial surgery. So for people who want to change the shape of their face, their hairline, tracheal shaves is like the reducing and reshaping of the thyroid cartilage and the Adam's apple. And again, the voice surgery, which helps with the vocal cords or tension to elevate pitch. Next slide, please. And back to you, Sarah, about legislation.
I'm going to just kind of fly through these slides really quickly since I want to leave a little bit of time for questions, but I just want to point out that there's a lot of different legislation that is in process nationally. Some of this legislation aims to criminalize healthcare actions. Some of this aims to criminalize parents trying to get gender affirming care for youth. There's also legislation that would restrict insurance coverage, and then other types of social restrictions such as bathrooms, sports, inclusive education. And though many of these policies have not necessarily been associated with healthcare use or lack of use, living in states with more protective policies is associated with an reduced odds of avoiding healthcare because of mistreatment. This is a state map that just shows kind of density of types of legislation that are anti-transgender throughout the United States. This is a map that is a composite score based on legislation having to do with discrimination, identity documents, and health insurance policies, with the dark green states being states that have more protective legislation and the dark brown states being ones that have least protective legislation. And so I think, with this population, it's important to think about advocacy as we would advocate for any of our patients. Things that we can do as providers is, first of all, understanding that our attitudes matter in terms of these patients. We may not feel that we are experts that are equipped to treat these patients, but the way that we interact with these patients is going to determine how comfortable they feel accessing care in the future. So you can refer out, but understand that how you treat people matters in terms of these first interactions with healthcare. Know your resources for gender diverse patients in the area. There's a couple of resources here. The Trans Friendly Project or resource guide is specific to the Boise area. Participate in dispelling myths about transgender and gender nonconforming people to your legislators, to your peers, by being educated. And then educate yourself, know what's myths. There's a lot of misinformation in the media right now. So being well educated about the realities of what transgender care really is. And then I think also important to understand our own bias and what gets in the way of being able to provide adequate care. Know that language can be a difficult thing to change for us, but we all made it through med school. So I have faith that we all have the ability to learn these changes in language as well. We all make mistakes. And so I know it can be challenging and feeling like you're going to make a mistake with patients that you don't feel as comfortable with their care, but we are lifelong learners. And so it's okay to make mistakes and learn from that. And you may not agree with transgender care. You may not agree with transgender people, but that doesn't mean that we can't provide high quality care. We don't agree with lots of our patients' decisions. It doesn't mean that we don't provide them with the right kind of care and education. And then this last thing, it's rare. Why would I care? I live in Idaho. It's a conservative state. And I think, you know, there are transgender people in Idaho. There are gender nonconforming people. There are intersex people. And we may not know that about them, but being more open to taking care of these people, we may find out that we do have some of those patients in our area. So I'll go ahead and stop there and see if there's
Thank you both so much for your presentation. Really appreciate it. And this is being recorded, and we expect early in 2023 to have this posted on our website. But we do have a question from Dr. Bolt. What is the source of the quote, standards of gender affirming care? Where can we find them? Just so you know, Dr. Lasko put in a link to TransCare UCSF, but I'll let you add to that.
Yeah, thank you, Dr. Laska, for adding that. I appreciate it. Yeah, there's 41 there. That website is super incredibly helpful in terms of like if you are treating or helping take care of a transgender patient, it really like can walk you through all the things, and where I got a lot of my information. But I'm sure Sarah has some.
the TransCare BC also has this primary care toolkit, which a lot of the information from this presentation came from. And then there was one other citation. Oh gosh, where would I find it? It's WPATH, so the World Organization for for Transgender Care has a guide as well that I am trying to find here and to point that out. As I do that, any other questions?
And I'm putting one of the WPATH links into the chat right now in case that's helpful. It's something I've been looking at. You can take a look and say if it's not helpful, but I just put that into the chat. Other questions? Feel free to unmute or type your questions into the chat.
Yeah, and WPATH has now a 7th, here it is. Nope, that's not it. Yeah, standards of care for here, that's WPATH's version 7.
Other questions? I'm not seeing anything in the chat, but feel free to put it there or unmute yourselves. All right. Well, Doctors Bardwell and Haughton, thank you so much for that very comprehensive presentation. We really appreciate the information. For those of you joining, if you haven't already, please fill out the Google form to get credit for today's CME or email me. That information is in the chat. There are a couple links that were also shared in the chat. And our next Grand Rounds is on Monday, December 12th at 11:30 a.m. PT, 12:30 p.m. MT with Full Circle Health Boise on social media and smartphone use amongst adolescents, current evidence update with Dr. McGrath. So we hope you will join us then. You can use the same link you used to join today's event for that event in December. So Doctors Haughton and Bardwell, is any other final words before we close out?
Thanks so much, everybody.
Thank you so much for coming. Really appreciate you guys, and go team.
Thank you again so much, and we'll see you all next month.